So this is notes on cranial nerve lesions. We should know the origins of the cranial nerves usually. 3 and 4 is from the midbrain. 5 to 7 is from the pons. There is a picture I will share. And then 9 to 12 is from the medulla. So we read that one minute. Okay, now you can see, sorry, I was talking with the mute mic. Okay. So this is the third nerve, oculomotor, and the fourth nerve, this is trochlear. He said the third and fourth from the midbrain. And fifth, that is the trigeminal. Sixth, seventh, and eighth from the pons. Then 9, 10, 11, and 12 from the medulla. Okay, these two, olfactory and the optic, will arise from the cortex. Any comments before we proceed? Is it clear for all?
Sorry, Doctor, can you repeat it?
Yeah, so if when we read in the mark, he said, so I just wanted to make it through the picture so that we will remember it. So the 3 and 4 is from the midbrain. Okay, 4 nerves, 5, 6, 7, and 8 is from the pons. Okay, so this is the trigeminal nerve. This is the facial nerve. Sorry, trigeminal nerve. 5th is the abducent, 7th is facial, and 8th is the vestibulocochlear. 4 from the pons. Now the remaining 4, that is the glossopharyngeal, vagus, accessory nerve, and the hypoglossal nerve from the medulla. Okay. Now we will go back to the mark. Sure. Okay. Now let's go to the olfactory nerve. It transverses the cribriform plate to the frontal lobes. So the lesions are most commonly detected in upper respiratory tract infections. So whenever we may have upper respiratory tract infections, we may have loss of tastes, loss of sensation of smell. Nowadays, it's more common with COVID-19. Okay. So the lesions are most commonly detected in upper respiratory tract infections, and another thing is the basal skull fractures and meningitis and in hydrocephalus. Okay. Just remember this nerve. I don't know whether it comes commonly or not, but we should know. So it transverses the cribriform plate to the frontal lobes. The lesions are most commonly seen in URTI and also in basal skull fractures and meningitis and hydrocephalus. Remember, anosmia is also occurs in Kallmann syndrome, which is associated with hypogonadotropic hypogonadism caused by embryological neuronal migration defect. We all know that in Kallmann syndrome, there is anosmia. Just remember this much only. No need much about this nerve. Next, we'll go to the optic nerve. This is very important. In exam, in the examination of eyes can be one station. Okay. Nerve fibers pass through optic disc to the optic nerve. Okay. From the optic disc to the optic nerve, nasal fibers decussate at the chiasm, and optic tracts carry impulses to the lateral geniculate bodies. We will see a picture for this. The optic radiation carries impulse to the visual cortex. Okay. So first, what happens? Optic disc to optic nerve, then nasal fibers will decussate and the optic at the chiasm, and the temporal fibers won't decussate, they go like that only. Then optic tracts are formed, which carries impulses to lateral geniculate bodies, and the optic radiation carries impulses to the visual cortex. So patterns of visual defect, we don't need much. We should only know these 4, whatever is mentioned. There are many things, but more common, and 4 if we know, it's more than enough. So blindness in one eye, retinal lens or optic nerve, chronic uveitis, optic nerve glioma, optic atrophy, septo-optic dysplasia. These are the common causes. So anything which causes injury to the retina, or there is a problem in the lens like full cataract or like retinoblastoma or anything, and optic nerve, there can be blindness in one eye. This can happen commonly with chronic uveitis, optic nerve glioma. I think gliomas are common with neurofibromatosis. Okay. And even in optic atrophy and septo-optic dysplasia, you can see blind eyes. Okay. I think there was one video station about septo-optic dysplasia before. Okay. Next is the bitemporal hemianopia. That is when the patient presents commonly with bitemporal hemianopia, craniopharyngiomas, pituitary tumors affecting the chiasm. Okay. Then homonymous hemianopia, contralateral lesions posterior to the chiasm in the optic tract. So here, for bitemporal hemianopia, the problem is at the chiasm. Next, for the homonymous hemianopia, the problem is in the optic tract. We will see the picture, then we will get to know. I'm just reading it now. This can be seen in cortical lesions such as cerebral palsy. You can see this homonymous hemianopia in cortical lesions such as cerebral palsy also. So scotoma, irregularly shaped visual field deficit arising from anywhere along the visual pathway, could be bilateral or monocular. I think this scotoma is a spot in your visual field where you don't see anything. Okay, so telling irregularly shaped visual field defect arising from anywhere along the visual pathway, could be bilateral or unilateral. Okay, so let's go to the picture now and then we will discuss. You can't see again. I don't know why we can't see. You can see now or no? All right, let me keep it here. Please take care of mics. I don't know, someone's mic is open. Now you can see the picture. Hello?
Yes. Yes, yes, yes.
Okay, so let's not go into everything. Only we will go for the things what we read. Okay, so blindness, this is the here like this. You will not see anything in one eye. This is completely blind. So the common is the lesion of optic nerve, that is ipsilateral monoocular visual loss, like this. There will be a lesion in both. These are the nasal fibers. The blue here is represented as nasal fibers, the red here as the temporal fibers. So when there is lesion here, you will have complete blindness. Then lesion at optic chiasm, that is bitemporal hemianopia. So this is the here is the entire, means here there is lesion in both nasal and the temporal. Okay, so how do you see? You will see the nasal portion, but you will not, the name suggests bitemporal hemianopia. So you are not seeing the temporal part, but you are seeing the nasal part only. So the lesion is at the optic chiasma. Okay, this is explained there. And next is the optic tract lesions. So in the optic tract, what happens? Suppose if this is the right eye, you will receive here the temporal fibers of the right eye and nasal fibers of the left eye. Okay, so you will have what? Homonymous hemianopia. That means in this eye, that is the left eye, you're seeing the temporal part. In the right eye, you're seeing the nasal part. So one side of the vision is okay with you, but the other side you can't see. So usually it will be contralateral homonymous hemianopia. That means if the lesion is on right side, you will not see the temporal and the nasal portion on the left side. Okay, so this is contralateral homonymous hemianopia. Okay, the other thing he explained was the scotoma. These things I think we don't want, because I don't think we will go into so much deep. Just know some of the common causes for the blindness and some videos which can come in the exam. Okay, so before I close this picture, anyone has any comments? Okay. So next screen. So just remember the blindness of the one eye, you should have the problems with the optic nerve. The most common problems we see is from the chronic uveitis, optic nerve glioma, optic nerve atrophy, and septo-optic dysplasia. And also the problems in the retina and also the lens can also cause. Okay. Next, for bitemporal hemianopia, that is the problem is at the optic chiasm. We know that the craniopharyngiomas usually in that place. Okay, so pituitary gland tumors and the craniopharyngiomas. These two examples are more than enough. Then for the homonymous hemianopia, contralateral lesions posterior to chiasm, that is the optic tract lesion, and the vision is affected on the contralateral side. You have to remember. Okay. So, suppose the right optic tract is affected, you will not see the left temporal and the left nasal. Okay, it is contralateral. This can be seen in cortical lesions such as cerebral palsy. Okay, you can see, just remember this example. And scotoma, anywhere there is a defect in the vision, that will be seen as the black. Okay, so irregularly shaped visual defect arising from anywhere along the visual pathway could be bilateral and monoocular. Next, we will go for the this oculomotor nerve, trochlear and abducent nerve. Okay, these three nerve videos for the eye is very common videos in exam. Okay. They can ask you these three. Okay, see again I am telling you, if repeatedly, if the same person has problem in opening the mic and disturbing, I will remove you from the meeting. Okay, please don't mind. Take care of your mics. If you want to speak when we are discussing, no problem. Otherwise, take care of your mics. So let's go to the oculomotor nerve. After reading this, we will see the picture. Okay. This nerve supplies we have to remember all the external ocular muscles, extraocular muscles, except superior oblique and lateral rectus. Leaving these two muscles, all is supplied by the third nerve. So this nerve supplies inferior, medial, superior rectus, as well as the inferior oblique muscle. Palsy is apparent as you will have dilated pupil that faces down and out. We should always remember it's down and out and the dilated pupil, and also there will be ptosis. So usually it can be congenital, associated with chromosomal abnormalities, or even in cerebral palsy. Acquired palsy, so from the birth the child was okay, but suddenly this happened, may indicate tumor, infection, or head injury. For all cases in CNS, you can remember trauma, tumor, infection, trauma, tumor. This is the broad differentials you can always give in acquired cases. Okay, trauma, tumor, infection. So for the third nerve, remember all the extraocular muscles except superior oblique and lateral rectus is supplied, and the presentation will be dilated pupil, ptosis, dilated pupil, and the eye will be down and out. Okay, down and out, and the causes can be congenital and acquired. Congenital is the chromosomal abnormalities or cerebral palsy, and in acquired, trauma, tumor, and infection. Okay. So why the eye is down and out? Because it is of the unopposed action of the inferior oblique and the unopposed option of action of the superior oblique and the lateral rectus. Okay, I'll share the picture now. Okay. A minute. This is the picture for the oculomotor nerve palsy. So you will have ptosis. What is the reason of ptosis? Because the muscle levator palpebrae is supplied by third nerve. So in activation of that muscle, you will see the ptosis. And there is mydriasis, that is dilated pupil, decreased tone of constrictor papillae muscle. The constrictor papillae is again supplied by the oculomotor nerve because of that. And you will see the eye down and out. The reason is unopposed action of the superior oblique and the lateral rectus muscle, because the lateral rectus will pull the eye towards lateral side and the superior oblique will pull it to down. Okay, the action of the inferior oblique and superior oblique is opposite. Okay, superior oblique will pull it down, but inferior oblique has a tendency to pull it up. But the opposite we see in trochlear nerve. So when we discuss, we will get to know. Okay. So this picture is important to remember the three things what we see in the oculomotor nerve. You can get a video like this, a person, a child with ptosis and down and out eye. And when you compare to this pupil, the another pupil will be dilated. Okay. So ptosis, mydriasis, and down and out eye. This is the feature of the third nerve palsy. Okay. Before we go to third nerve, is it clear? Sorry, fourth nerve.
Yes, doctor.
Okay. Let's go for the so the trochlear nerve, this nerve controls the superior oblique muscle and has long intracranial course. Okay. Palsy usually presents subtly as the head tilt towards the unaffected eye. Okay, you will see an head tilt when you're when you're observing the video. You should also observe for that. In trochlear nerve palsy, usually there will be an head tilt. Okay, palsy usually presents subtly as head tilt towards the unaffected eye. Means suppose if the left eye is affected, the tilt of head will be seen towards the right. Okay. On examination, there is upward deviation. In oculomotor, we saw down and out. Here, there will be upward deviation of the eye and failure of downward and lateral gaze with diplopia. So it will be opposite. Here, there will be upward deviation. Okay. Again, the causes include, here he told one point, it has the long intracranial course. So the causes include raised intracranial pressure as the nerve has long intracranial course. Will need surgical correction if head tilt is significant. Okay. I have a confusion about the abducent nerve and the trochlear nerve. The abducent nerve also has long intracranial course, or what? Can someone tell me?
I actually thought it's the abducent nerve that has the long intracranial path.
Then why he is telling here trochlear nerve?
I don't understand.
Yeah, even me, this is what is my doubt. And as I know, abducent nerve gets affected with the raised intracranial pressure, right?
Yes.
Yeah.
Okay, let's go back and check. Let me see if he has mentioned here.
Yes, but I think the trochlear nerve also has a long track, but the longest one is the abducent nerve.
Yeah, both have long, but the longest
Yes.
is abducent. Yeah, this can be a
But traditionally, we know the sixth nerve abducent as the longest.
abducent is the longest. Yes, it's accepted. But I think both have the long intracranial course, and both are affected in raised intracranial pressure. Let's see here. The abducent nerve controls the lateral rectus muscle. Lesions of this nerve cause marked convergent paralytic squint. Yeah, the convergent paralytic because of the medial rectus becomes active than the lateral rectus. The affected eye is turned nasally and is unable to abduct fully. This condition is rarely congenital. So commonly you will not see. Congenital is seen more common with the third nerve. We read it here with the, I think with the cerebral palsy and chromosomal anomalies. This abducent is not common congenital. Acquired causes include raised intracranial pressure, tumors, AV malformation, and meningitis. Again came here, tumors and infection came here. So infection, tumors, AV malformation, and for these two nerves, 4 and 6, say about the raised intracranial pressure as well. Okay. So we will go at once to the pictures of both this affection.
Actually, for raised intracranial tension, always they say only about the sixth nerve.
Abducent, right? Yeah, let's go back and check. If it's given in this book, I think it has also to should be there. Let's go back and check when we have some doubt. Okay.
Okay.
And post in the group. Better. If he has told, I don't think that he has just mentioned like that. Maybe there is something. So we will check it. Again, for both trochlear nerve and the sixth nerve, he is telling the raised intracranial pressure. Okay. And if the head tilt is too much, it needs surgical correction. Remember this when you are asked, when you will be asked about the management. Here again, there will be raised intracranial pressure and long, because the raised intracranial pressure affects because it has the long intracranial course. Next, tumors, infection, that is meningitis, and AV malformation. Okay. So 1 minute.
Yeah, I checked it in up to date and also in PubMed. The trochlear nerve has the longest intracranial course.
Can you tell me again what?
Yeah, I checked it for the trochlear nerve in the up to date and in PubMed that the trochlear nerve has the longest intracranial course, even longer than the abducent nerve intracranial.
Okay, maybe if he has given, yeah, we didn't know all these days, yeah. You're right. So both the nerves we consider in raised intracranial pressure, okay? So here for the trochlear nerve, if you can see here, so cranial nerve palsy, he's feeling cranial nerve palsy on the right eye. Okay, this is the right eye of the patient and there is palsy here and the head is tilted towards the left. Always remember, if there is right eye palsy, the head is tilted towards the left. So opposite side, the child will tilt the head. This should be your observation when you observe in the video. And also, if you observe here, you see this is the normal eye which is in the central position. If he is keeping his head straight, you will see that the eye is up. You can see here the eye is up. Now, what does he tilts his head to the left to bring it in the center so that the both will get aligned. Okay, so right eye, now this is the right eye of the patient, okay, is extorted and slightly elevated, causing double vision. So here the right eye is slightly elevated here, it is causing the double vision. Okay, so to compensate this, patient tilts her head to the left. So tilting will bring both these eyes in one position, that will prevent double vision, because double vision is irritating, it will cause headache. Again, the so the reason for tilting tilting of head in the fourth nerve palsy is the discomfort and the double vision. Okay, as we see here, the one eye, suppose if there is right sided palsy, it will be towards up. Okay, and to bring both the eyes in one gaze position, the patient will tilt. Usually if it is right sided palsy, fourth nerve palsy, the patient will turn towards the left. We should know this. Okay, towards the normal eye there will be a tilt. So right eye is extorted and slightly elevated, causing double vision. To compensate, the patient tilts her head towards the left. Okay, this is normal eye rotation. Normally when we rotate, both of our eyes will come in same position. Here, see, in normal position, the eye is up, is towards up. Okay, up and out, towards up and out. So he is tilting his head towards left to bring it into position to avoid double vision. Okay, if there is a tilt, suspect fourth nerve palsy, but still observe for other findings to help your information. I'll share some more pictures.
അത് ചോദിക്കണ്ടായിരുന്നല്ലോ അത്ര സമയം എടുക്കും ഇങ്ങനെയൊക്കെ ചെയ്യുമ്പോൾ ചോദിക്കണം ഇത് എപ്പോ ആകും നമുക്കൊരു ഐഡിയ വേണ്ടേ അതിൽ പോയിട്ട് ഇതിൽ വന്നില്ലെങ്കിൽ അതിന്റെ പ്രശ്നം.
So you can see here, I don't know why it is so small. You can see in this eye here, can someone tell me which eye is problematic here, right or the left?
Left.
Okay, left. Why you are taking left? Can you tell me?
Hitting the head towards the right.
Yes, he is tilting the head towards the right. Good point. Apart from that,
Yes.
the position of the eye, usually in the fourth nerve, it will be toward up, right?
Lateral rectus palsy, sixth nerve.
No, this is, I am talking about fourth nerve.
Hmm?
Fourth nerve supplies superior
Ah,
oblique.
yes.
What is the action of the superior oblique? What is the action of the superior oblique?
Superior oblique is inferior and medially.
No, it will be in and up, inward and upward.
No. Inferior and medially.
Yes, that is
Yeah.
the function. But when it is paralyzed, the eye will be moved to the up because the inferior oblique. So
He
the
asked
fourth
the
nerve is not
function.
functioning. It is not functioning. That why eye has been deviated up.
Yeah, she was asking what is the function. So function is in and medially, in and lower.
The superior oblique function is to pull it down, not pull it
Yeah.
Yeah.
down.
So
Down
it becomes
and
weak.
in or down and out? This is my question.
Down and in, adduction.
So the usually
Excellent.
the eye deviation will be in fourth nerve. It should be up and out, right? If you keep the head straight, the eye deviation will be up and out. When he tilts, it becomes like this. I hope it's clear for you.
Yeah. See, to move the eye outward, you have to have the control over medial or lateral rectus. Okay, if both the nerves are intact, the eyes will not move in or out. But yeah, up and in this like this in this picture, this is like looking up and medially. So can be SO4 lesion, superior oblique lesion. Hello? Hello?
No,
Hello?
the superior oblique function is down and in. The inferior oblique function is up and out. Yes or no?
Yes.
Yes.
So what happens in fourth nerve palsy? If you keep the head straight, the eye will be up and out. Okay, slightly towards lateral. Not too much lateral, complete lateral action is by abducent nerve. But in the, in the angle, I will draw for you. Just wait, it's better to draw. Now, the action of the superior oblique is down and in. So it is like this. Okay, the action of the inferior oblique is up and out like this. So
that is up and in. No, inferior oblique is up and in. Out is by the superior rectus.
Superior oblique is down and in or down and out?
In.
For
Oblique
which
function in adduction.
For
Oblique function in adduction, rectus function
For
in
which
abduction.
eye, right or left, you draw?
Whatever, in general, tell me. Okay, let's
So see, the superior oblique is, the function is to in and low. But in lesion, it will come the opposite, just opposite. That is up and out.
That is what I am telling. Let's first talk about the
But Dr. Noor, the function of inferior oblique is up and in, not out.
Okay. So this is for the lateral rectus, okay? Lateral rectus palsy, you will see the eye medial. No confusion in lateral rectus, okay? Just you will see medial. Again, the common is the tumor, raised intracranial pressure, and you can put infection also. Even in the fourth nerve, raised intracranial pressure, tumor, infection. Congenital is more common with the third nerve and also the congenital chromosomal abnormalities and even cerebral palsy, you see third nerve, and acquired will be tumor, trauma, infection. Okay. Yes, someone was telling something. It's always confusion in the exam. So you should have some clues here. Again, I will show you this picture. 1 minute.
For etiology in any CNS case, we have to tell 5-6 causes like tumor, trauma, infection, right? Any
Yeah, keep it
surgery.
common. Keep it on the
Okay,
top.
for like,
Trauma, tumor, infection. This is
any
on the top of
surgery,
everything. Yeah.
any surgery or any cerebral palsy, any degenerative changes like this.
Mm. Always remember this for the fourth nerve. When the head is straight, you will see the eye up and little out, not like up and little out. But for the third nerve, it will be down and too much out because there is lateral rectus also, which is dragging it. That's why along with the superior oblique, there is lateral rectus also. All other nerves are paralyzed in third nerve. All other muscles are paralyzed in third nerve palsy. So the eye will be down and too much out, but here it will be up and little out only. So when he tilts the head, you cannot see, maybe it will come to the center, but still you will see it little up. See, it will not come like this. It will still be little up. So he will tilt towards the opposite normal side. This much, if you remember, it's more than enough. No confusion. And for the lateral rectus, it's very clear. It will come in the medial side, and the common cause for fourth and sixth nerve, always say raised intracranial pressure along with tumor, trauma, and infection. But put for third nerve, congenital causes also you have to put, okay? Like cerebral palsy and some chromosomal abnormalities. That's what I got from the mark. Okay, so we are done with oculomotor, trochlear and oculomotor, trochlear and abducent nerve is finished. Let's go to the trigeminal nerve. Has three sensory divisions, ophthalmic, maxillary and mandibular, which pass into trigeminal ganglion at the apex of the pitreous temporal bone. The motor fibers originate in the pons. As we read, pons is for 5, 6, 7 and 8. So the motor fibers originate in pons and supply the muscles of mastication. We saw yesterday how to examine and all. No need to go for that. So ophthalmic, maxillary, mandibular sensory divisions. They pass through the trigeminal ganglion at the apex of the pitreous temporal bone. Motor fibers from the pons. And we know masseter and temporalis is supplied. And also yesterday, pterygoid muscle. We discussed that pterygoid is also supplied by this. Lesions are caused by brainstem gliomas, infarction, AV malformation, acoustic neuromas, CSOM, and cavernous sinus thrombosis. Yeah, cavernous sinus thrombosis you can put for many nerves in the CNS. Okay, so brainstem gliomas, because now it is all these nerves are arising from the brainstem, right? Pons. So brainstem glioma, infarction or AV malformation, acoustic neuromas, and CSOM and cavernous sinus thrombosis. Next is the facial nerve. This is the most common exam case. The facial nerve has long intracranial course. Initially, it is closely related to sixth nerve. That is, lesions in pons therefore tend to affect both nerves, and then it emerges from the cerebellopontine angle, CP angle. Lesions here also affect nerves 5, 6, and 8. As we know that 4 nerves come from the pons and they are close to each other. So the lesion of one nerve can affect other nerves also, and runs in pitreous bone in close relation to middle ear. So many nerves have long intracranial course, but the longest is the trochlear nerve. Watch what we read today. So even this nerve has a long intracranial course, and it is closely related to sixth nerve. We saw the picture before. All these lesions in the pons therefore tend to affect both nerves, and it emerges from the cerebellopontine angle. Lesions here also affect the nerves 5, 6, and 8. So we have to tell all these nerves are related. If one nerve is affected, try to test the other nerves also. Maybe there is something you may get it. That is what he used to. Suppose if they give you the facial nerve palsy, and if you think that it is upper motor neuron, try to check for other nerves also along with it. 5, 6, 7, and 8. Okay, yesterday we saw the examination part. Okay, and runs in pitreous bone in close relation to the middle ear. It is key to remember upper motor neuron lesions causes weakness of the lower part of the face on the side opposite the lesion. The forehead is spared as bilaterally innervated. So we will remember upper spares upper. So the upper motor neuron lesion spares the upper part of the face. So only if it is right-sided upper motor neuron of the facial nerve is affected, that means you see only the left lower part of the face, facial palsy. Lower motor neuron lesion causes weakness of whole side of the face on the same side as lesion. This is very common, all of us will know, so we will not spend more time on this. Auditory nerve, 8th nerve, passes through the CP angle. Again, you see 7th and 8th, they are very close to each other. He said here also, it emerges from the cerebellopontine angle. Both are very close. So if one nerve is affected, there is a chance that another is also affected. So if you see, you should just offer to examine these nerves also. If there is time, do it. If you did not do, at least offer that I want to check this nerve also, like this. Glossopharyngeal 9th, vagus 10th, and hypoglossal 12th. All leave through the jugular foramen and are affected by lesions at the base of the skull, such as achondroplasia. So if you can get a case of achondroplasia. In that, maybe in order to complete, if you get in other station or in musculoskeletal station, you may have to tell, in order to complete your examination, you will also do the CNS examination. Okay. Tell me about Arnold-Chiari malformation. Which conditions may have this malformation? Anyone?
Which condition? Which malformation?
Arnold-Chiari. You
Arnold
think
Chiari
which
malformation.
conditions Arnold-Chiari?
Arnold Chiari is associated.
That cerebellar lesion, cerebellar.
No. Arnold-Chiari, yeah, means the part of the brain stem will be herniated through the foramen magnum. This is Arnold-Chiari, right? The part of the brain stem will be herniated through the foramen magnum. Okay.
Through foramen.
Yeah. You see in Down syndrome also, and achondroplasia. Any other conditions anyone can add up, please?
For this, cerebral tumor, any like medulloblastoma and all will be affected. This 9th, 10th, and 12th. Anything in the posterior column will affect this.
Posterior column.
Not posterior column.
Sorry, I'm to the cerebellum. Sorry,
Posterior fossa.
Posterior fossa.
posterior fossa. Today I'm totally lost. Posterior fossa. Yes.
If you read too much, we will be lost. That's it.
No, sorry. Posterior fossa. Cerebral this osteocytoma, medulloblastoma.
No, you should know at least few of the conditions. I remember it's
Atexia,
Down syndrome
telangiectasia.
and also achondroplasia. Okay. This two I remember. Another, let's go back, check our post in the group. Okay. This is very common. This is herniation of the lower part of some part of the brainstem into the foramen magnum.
The cerebellar tonsillar herniation.
Yeah, it's the, wait 1 minute, midbrain pons medulla. It's medulla or cerebellar tonsil herniation? And there is risk here, right? Because there can be compression on the respiratory centers. There can be compression, and this is the risk here.
Respiratory centers in medulla.
Yeah, okay, but just let's read about it, okay? Tomorrow we can discuss. It's very important, Arnold-Chiari malformation. So facial palsy, we all know, examination. First thing, if you go from head to down, you will ask to frown, and then you will ask to close the eyes. Frown, raise eyebrows, then close the eyes, puff out the cheeks, whistle, and close eyes, keep them closed against resistance. Just do it from up to down always, so that we'll not forget. So in the forehead, you will ask to raise the eyebrows up and compare on both the sides. Is he doing equal or not? For the eyes, you will ask to close. In LMN, you will see the open eye, and also you may ask, check against resistance, ask them to close tight and you try to open it. Okay, then blow, puffing out cheeks, whistle, and smile. Okay, finally offer to check blood pressure. Look in the ears for the signs of infection or rash. So don't forget, you have to tell always that you want to look into the, if it's a video station, you want to look into the ear to see the signs of infection or rash. Inspect the skin for rash. This is erythema migrans, okay, for Lyme's disease. Assessing hearing, that is because if there is acoustic neuroma, it can also affect the facial nerve. That's why these nerves are in the CP angle 7 and 8, they are very near. So you will also tell in last, in order, you will also assess hearing. Okay, maybe if it is a clinical station, you will tell in order to complete my examination, you will do assessment of vision, hearing. Okay. Look for signs of exposure of keratitis in the eyes for incomplete lid closure. Okay. This is very important. Whenever there is facial nerve palsy, you will look into the ears for signs of infection and look into the skin for rash of erythema migrans. This is for Lyme's disease. This is for Ramsay-Hunt syndrome. And if acoustic neuroma, so you will say you don't know if this is the cause. So you will assess hearing and exposure keratitis in the eye for incomplete lid closure. Lower motor neuron affects upper and lower face. Upper motor neuron lesion spares upper face. Okay.
Yes. So I think enough for today.
Yeah, finish. Only this, we will finish the facial nerve and we will stop because the topic is changed next. Next, the topic is changed.
And if you want to give me clinical scenario,
Actually,
tomorrow.
it takes time to prepare. I'm not preparing. I'm just first putting myself to know the things, what is right. And then let me see. I'm not sure. Okay. Or we can do it tomorrow, no problem.
Yeah, better tomorrow. Yes. Large topic.
No, this is just facial nerve. Just finish the facial nerve and we will stop. So etiology of facial nerve palsy. This is the LMN and upper motor neuron. They have written separately. Okay, lower motor neuron lesions, upper motor neuron lesions. So let's go for the upper motor first. Cerebral palsy, tumors, Mobius syndrome, loss of function of motor cranial nerves. Child will have strabismus and immobile face because cranial nerve 6, 7 most commonly affected, and this is extremely rare condition. Okay, you will also see the squint because facial nerve 6 is affected. Okay, so there can be squint and 7 can cause the upper motor neuron type of facial palsy, but he is telling it is rare. Usually it is involving the cranial nerve 6 and 7. Next is the CP and tumors. For the lower motor neuron, you have wide differential diagnosis. Bell's palsy, it is idiopathic. Then CSOM, then viral infections, you have mumps and Epstein-Barr virus, Ramsay-Hunt syndrome, Lyme's disease, Guillain-Barré, usually it will have bilateral but can present as unilateral also. Then congenital, trauma, skull fractures, intracranial tumors. See again the leukemia. So again tumors came here, trauma came here. Okay, CSOM, infections. So you can keep in all CNS infections, trauma and tumors as your broad differential. Upon that, you can say particular things, that is the Ramsay-Hunt syndrome and Lyme's disease. All these will come under infections again, Ramsay-Hunt syndrome, Lyme's disease. Okay, so Guillain-Barré is post-infectious sequelae it is. And then you will have Bell's palsy, the idiopathic one. So usually unilateral, the Bell's palsy. What is the management? Exclude hypertension. So you will also tell, you will check PP. Okay. Exclude other causes. Before diagnosing Bell's palsy, it's a diagnosis of exclusion. You should exclude Lyme's disease. In Lyme's disease, it will be bilateral usually. And even in GBS, it will be usually bilateral. Okay, if you see bilateral facial palsy, put this on the top, GBS, Lyme's disease. Okay, Lyme's disease, particularly if bilateral. Many centers advocate Borrelia serology testing for any patient with Bell's palsy who has visited a tick-infested area in preceding few months. Okay, So also you can put Borrelia serology. Okay. This is for Lyme's disease. Many centers advocate Borrelia serology for testing any patient with Bell's palsy who has visited tick infested area. If there is history that they visited the tick infested area, you will suspect the Lyme's disease, but usually it will be bilateral. Other thing you have to rule out is the varicella from history, examination, and varicella titers. Okay. Next is the leukemia through examination, screen with full blood count and film. So leukemia, not just facial palsy. Along with facial palsy, you will have other things like lymphadenopathy, petechiae, pallor, some things. If you suspect thing, you will do FBC and film. So for herpes zoster, varicella infection is very important. You will rule out by history, examination, and varicella titers. And Lyme's disease, that is Borrelia serology, if they have gone for the tick infested areas in few months. Eye care, don't always tell eye care in facial nerve palsy. Good eye care is very important. Tape the eyes and shut at night and use artificial tears. So you will tape the eyes and shut at night when the child is sleeping because they will cause exposure keratitis, and during the day you can use artificial tears. So eye care is important. Treat with steroids if less than 7-day history. You will give steroids if less than 7-day history. Oral acyclovir has been used usually in conjunction with steroids, but there is no clear evidence of benefit unless the child has Ramsay-Hunt syndrome. So you can add the oral acyclovir, but they are telling it has no clear evidence unless there is by your examination or you by doing varicella titers if you are sure that it is Ramsay-Hunt syndrome. Prognosis is generally good and better in children than in adults. Most patients show signs of recovery by 3 weeks to 3 months. If lost over 3 months, MRI should be considered. So by 3 weeks to 3 months, if you are suspecting after excluding other diagnosis, it is Bell's palsy, by 3 weeks to 3 months, they will recover. If it persists beyond 3 months, you will go for MRI. This question can be asked in the exam. Okay, when do you go for imaging in this patient? If they ask, we will say that it has to be improved by 3 months. If it is not improved, you can go for MRI. And along with this, we can also add physiotherapy. Okay, and I am not sure about this oral acyclovir, about the present. Anyone has any updates from the new what they are giving for Bell's palsy? Are they giving just steroids or they are also adding oral acyclovir as routine? Means this book is from 2016. Any updates from the new sources? Anyone?
It is written in the Red Book guideline. There is Bell's palsy guideline. Just the corticosteroid if the presentation less than 72 hours.
Okay.
Per adult as adult guidelines. It is written in the Red Book.
Okay, you will start corticosteroids. Here he is telling 7 days. They are telling 72 hours, right?
Yes, 3 days.
Less
if the
than
presentation within 3 days, give oral corticosteroids.
Okay, what about oral acyclovir? You are not giving routinely.
No, not routinely, just with Ramsay-Hunt.
Just with Ramsay-Hunt. Okay. Okay. If you know the page number, just tell me. I will go through later about it from the Red Book.